Welcome to MedUPTICK, where we take your test-taking skills to the next level. Ready to walk through another high-yield USMLE-Style vignette? Then come on in. Let's get started. Okay, this question is a bit lengthier and may make you initially nervous. However, we will break it down step by step, making getting to the correct answer very feasible. Whenever I attempt an MCQ, I always read the stem of the question first to get an idea of what to look for as I read the vignette. So let's start there. Which of the following is the most likely diagnosis? Diagnose the patient questions tend to be pretty straightforward. So on to the vignette. A 74-year-old man with a 5-year history of chronic lymphocytic leukemia presents to the clinic with new onset fatigue, night sweats, and an 8-kilogram weight loss over the past 4 weeks. He reports daily fevers and progressive weakness. These symptoms are relatively new, having occurred over the past 4 weeks. Fatigue, night sweats, daily fevers, and what appears to be unintentional weight loss can be characterized as B symptoms. Their presence gives the impression that the disease is potentially progressing. His CLL has been managed with watchful waiting, and his most recent clinic visit 3 months ago showed stable disease. Past medical history includes well-controlled hypertension on lisinopril. He denies any new medications. So his disease has been stable based on his most recent visit only 3 months ago, without any recent changes to the treatment regimen, leading us to think the symptoms are entirely related to the disease as opposed to external factors. On physical examination, his temperature is 38.5 degrees Celsius, blood pressure 130/75, heart rate 92 beats per minute, and respiratory rate 16 breaths per minute. Multiple firm non-tender lymph nodes are palpable. Right cervical 4.5 centimeters, left axillary 3.8, and bilateral inguinal 2 to 3. The spleen is palpable 6 centimeters below the costal margin. This physical examination reveals the patient is currently febrile with well-controlled hypertension, and the remaining vital signs are within normal limits. However, his lymph nodes are enlarged and palpable with signs of splenomegaly. These additional findings further support worsening disease progression. Laboratory results show white blood cell count 80,000, up from 25,000 per microliter. Differential 85% lymphocytes, up from 75%. Hemoglobin 9.5 grams per deciliter, down from 11.2 grams per deciliter. Platelets 95,000, down from 145,000 per microliter. LDH 850, up from 195 units per liter, and beta-2 microglobulin 5.5 milligrams per liter, up from 2.8 milligrams per liter. The white blood cell count is markedly increased from 25,000 to 80,000 microliters, compounded by an increased lymphocytic predominance from 75% to 85% on the differential, which is expected in a patient diagnosed with CLL. However, the anemia and thrombocytopenia raise concerns that there is bone marrow involvement. The quadrupled elevation of LDH from 195 to 850 units per liter and the approximately doubling of the beta-2 microglobulin to more than 5 milligrams per liter are red flags. Both of these measures indicate high cell turnover and disease activity, pointing us further towards more aggressive malignancy. Peripheral smear shows numerous smudge cells and large atypical lymphocytes. The peripheral smear shows numerous smudge cells, also known as basket cells, is a classic finding in CLL. However, observing large atypical lymphocytes is unusual for CLL and suggestive of transformation. Flow cytometry from 3 months ago showed typical CLL phenotype, CD5, CD19, and CD23 positivity. PET-CT reveals multiple hypermetabolic lymph nodes with standardized uptake value greater than 5, including a right cervical node with SUV of 15. An increase in standardized uptake value further suggests aggressive behavior because typical CLL does not show significant PET avidity. An excisional biopsy of the right cervical node shows sheets of large atypical lymphoid cells with frequent mitoses. Immunohistochemistry is positive for CD20 and CD79A and reveals Ki-67 proliferation index of 80%. The biopsy findings are critical because sheets of large atypical lymphoid cells combined with a high Ki-67 proliferation index and positive CD20 and CD79A staining are the hallmarks of an aggressive lymphoid malignancy. CD20 and CD79A, or cluster differential 79A, are B cell surface markers. Ki-67 is a surface protein seen in dividing cells. Therefore, higher rate indicates that cancer cells are rapidly dividing. Which of the following is the most likely diagnosis? Based on the analysis of this question, we are left with a few differential diagnoses, which include Richter transformation, progressive CLL, infection, and secondary malignancy. Now we can review the answer choices. A. CLL progression without transformation. This answer choice can be eliminated because although CLL can progress over time, we identified earlier that this presentation is likely indicative of a transformation into a more aggressive disease, rather than simple disease progression based on the presence of B-cell symptoms, PET CT scan findings with multiple hypermetabolic lymph nodes, and the biopsy findings demonstrating high proliferation based on the high Ki-67 index. B. Diffuse large B-cell lymphoma transformation. This is a reasonable answer choice because CLL may undergo transformation into diffuse large B-cell lymphoma. Hence, we will keep this answer choice for now. C. Small lymphocytic lymphoma with progression. While small lymphocytic lymphoma and chronic lymphocytic lymphoma are two clinical presentations of the same disease, distinguished by the degree of lymphocytosis and organ involvement, SLL refers to the nodal presentation of CLL without significant lymphocytosis in peripheral blood. This patient already has confirmed diagnosis of leukemic CLL with large, not small, atypical lymphocytes on the peripheral smear. Additionally, SLL would not typically present with such severe systemic symptoms, so there's no indication that SLL is progressing. D. Hodgkin lymphoma variant of Richter transformation. CLL may indeed undergo transformation into Hodgkin lymphoma, although less frequently. So we will keep this answer choice as well for now. E. Mantle cell lymphoma. Although mantle cell lymphoma shares some clinical and pathologic features with the findings in this vignette, several key aspects of the case rule out this diagnosis. This patient has a clear 5-year history of CLL. MCL is a distinct B-cell malignancy that arises from the mantle zone of lymphoid follicles and does not share direct relationship with CLL. Although MCL shares CD5, CD19, and CD20 positivity, it also has a hallmark finding of cyclin D1 positivity due to translocation 1114, which is not mentioned in the vignette. And smudge cells are not observed in MCL peripheral smear, ruling MCL out as the correct answer choice. This leaves us at the 50-50 point between answer choices B and D. First, the biopsy findings support diffuse large B-cell lymphoma with sheets of large atypical lymphoid cells with a high Ki-67 index of 80%. In contrast, we know that Hodgkin lymphoma would show Reed-Sternberg cells and a mixed inflammatory background, which are absent here. Second, CD20 and CD79A positivity are hallmark markers for diffuse large B-cell lymphoma. Hodgkin lymphoma, however, is typically CD15 and CD30 positive and CD20 negative. Third, diffuse large B-cell lymphoma accounts for 90% of Richter transformations, while Hodgkin lymphoma is rare, occurring in only 5 to 10% of cases. In conclusion, B is the best answer to this question. CLL most often transforms into diffuse large B-cell lymphoma, and the findings of a high Ki-67 index, CD20 positivity, and PET avidity seal the diagnosis. I hope you enjoyed this question. If so, please click the like button and share this video with someone who may benefit from the content reviewed. If you don't want to miss any new USMLE-Style vignette walkthroughs, among other exam prep tips, make sure to subscribe to the channel and click that notification button. I look forward to hearing your feedback in the comments. Thank you. Until next time, stay sharp and focused and continue to elevate your clinical mastery.